રેકોર્ડિંગ કેમ કરે સાહેબ ને આમાં નહીં રાખ્યું કે બગાડે ખોટું.
हेलो हेलो मयूर भाई, डॉक्टर मयूर. हेलो
हेलो. हाँ सर.
हाँ मयूर भाई,
हाँ
कैन यू
सर.
शो द पोजीशन ऑफ द पेशेंट?
સર ડ્રેપિંગ ચાલે છે એટલે સર 2 મિનિટ સર.
ઓકે
ડ્રેપ
ઓકે.
2 મિનિટ સર
હા.
ડ્રેપ કરીને.
એટલે પોઝિશન છે ડ્રેપ કર્યા પછી કદાચ એટલી ક્લિયર ના દેખાય.
સર આઈ શો યુ.
supine position.
સુપાઇન છે સર.
neck
fully
must be
down and
neck,
10 degree tilt from the head side.
and neck also it must be extended.
અરે
neck extension છે neck
રાકેશભાઈ
neck extend કરી છે, shoulder નીચે મૂકેલા છે, shoulder back.
દેખાય છે સર પેશન્ટ હવે?
yes, now we can see the patient. Yes,
हाँ.
entire patient we can see.
Okay na sir.
Complete. So that painting we do from lower lip up to the nipple of the chest.
Yes sir. Normally we doing a painting in normal thyroid surgery.
Yes.
ऐसा ही painting है. और one more painting tapping in oral cavity.
Yes.
Sir is capturing one betadine gauze in oral cavity for 2 to 5 minutes.
Good.
That is a one extra thing for painting and draping.
Right.
In this case.
So because these are very simple questions, each and everyone must be quite well familiar with that. But the motto of asking this question is that others also they can follow.
Live ચાલુ.
આશીષ ભાઈ કેસો એનેસ્થેસિયા મને બતાવશો એનેસ્થેસિયા માં શું આવે છે?
કરવાનું હતું ને પહેલા.
હેલો આશીષ ભાઈ, ડોક્ટર આશીષ. ભાઈ છે એનેસ્થેટિસ્ટ?
Yes sir.
આશીષ ભાઈ તો જે શું આપે છે એટલે બતાવો તો સારું.
So we have induced the patient on
Yes, yes. Please go ahead. Yeah, we can see, we can hear also. Yes.
After pre-oxygenation, we have given
Okay.
induction agents as propofol and
Okay.
succinylcholine. And
Right.
we have done axometallic intubation
Pressure
and a
selection
nasal cavity
stuck one
on right
day
side.
and flow rate around 10.
We are now maintaining the patient on sevoflurane and
Okay. Sevoflurane with?
atracin. Atracin.
CO2.
Okay, okay, okay. Good. Thank you, Dr. Ashish. Thank you. अच्छा pulse BP કેટલું હશે? Pulse BP?
So right now heart rate is 92 per minute and blood
Okay.
pressure is 102 by 78.
How much?
102 by 78.
Okay, okay. This is quite low. એટલે
Yes, sir.
તમે જોઈને કદાચ બીપી નીચે આવી ગયો. આશીષભાઈ,
हाँ sir?
તમને જોઈને બીપી નીચે આવી ગયો.
ना sir.
પેશન્ટ નો, પેશન્ટ નો.
This was stool.
Hello. Monson, am I audible?
Yes, yes, we can hear you.
Very good afternoon.
Yes, good afternoon.
Thank you for this nice invitation and demonstration call.
Rather,
Excellent OT setup here. This is
good.
something which will not seen before joining any corporate to have
Oh.
this thing in such a wonderful setup.
Thank you very much for the
Atmosphere
compliment.
here.
Thank you.
And even all the anesthetists, they are so compliant with all my needs.
Right. I
Thank
think
you.
they talked with you also yesterday or day before yesterday.
Okay. So, so the initial preparation is done. We have
Good.
taken the patient in supine with extended neck
Extended neck. Yeah.
in a kind of a 10 to 15-degree Trendelenburg position, so that there is a slightly head lower for instrumentation.
Okay.
Apart from neck cleaning and painting and draping, like we always, for any minimal invasive surgeries anywhere in the
Yes.
body, always take a consent and probably prepare yourself for opening up the area, so that
Yeah.
in case situation you are prepared for external approach. So that is how we have prepared the neck also. You can see this region, that's the thyroid swelling, which was
Well, Siddharth bhai,
yes sir.
can you adjust this direction of the camera? But
Yes,
because
we'll
we're
show
not
you
able
the
to see
thyroid.
the,
We'll show you the thyroid.
yeah. Yes, now it's better.
Yeah.
Better.
So
Yes,
that's
good.
the thyroid like this,
Right.
which has already been discussed. Around 3.5 centimeter is the maximum dimension.
Okay.
3.5 or 3.4 by 2.1 by around 3.2. That's the
Okay.
probability with the
Compare
Bethesda.
volume.
Yeah, with Bethesda 2 as an FNSC possibility. So this is a benign thyroid lesion.
Okay.
And so our plan is a transferal approach of this thyroid nodule. So
Okay.
normally what conventionally we will do is use a external skin crease, open
Good.
up in
Yes.
the region, whatever is the nearest skin crease on the swelling. We open up in line and we do the thyroid swelling. I mean
Right.
thyroidectomy and
Right.
close this cut. Now the major problems related to that is you have a definite visible scar which heals. After healing, will give a definite visibility of that scar. In certain patients, you tend to have certain healing issues, like patients' inherent tendency for hypertrophiness or keloidal tendency, which will be in markedly here.
Right.
Even if it is nicely, there'll be a faint white line. Now, for an age group of this patient, which is not a concern, but
Mhm.
we know that thyroid is predominantly a younger. We have a predominantly a younger population, younger female population with thyroid swelling.
Right.
Majority of these thyroid swellings, they are benign.
Mhm.
Only
Yes.
10 to 15% will be malignant. So for a benign and solitary thyroid nodule in a younger population, this is one of the cosmetic approaches, I would say. It is
Yes.
no more otherwise superior to a conventional standard. It's more of a favorable aesthetically,
Mhm.
and something which has come up probably in this area. And there are people who would be desirant of avoiding any neck scar
Mhm.
for the thyroid swelling.
Right.
So the journey began with similar demand when I
Mhm.
started my first case of thyroid transoral. This was in November 2020, when a young girl from Surat, she approached me for scarless thyroid surgery
Mhm.
because she was still an unmarried girl, entrepreneur by herself, but she still wanted to undergo surgery before she settles down in life.
Mhm.
And that's how the my first journey of doing a transoral thyroid started.
Good.
So you have patients who would demand to prevent or avoid any neck scar. Otherwise, the technically, the outcome wise, it is almost similar. It's only the angle of working changes. The procedure remains the same. The few steps are different from the open surgical procedures.
Right. But I think
Overall,
majority of the steps they are almost similar to the open
yes,
technique.
sir. Yes, sir. So ultimate outcome is same. There are certain myths, or maybe you can say misconceptions still, because still this is not a very standardized or very popularized process or technique. This has just started in 2016, in which was popularized by Dr. Angkun Enuwong in Thailand, Bangkok.
Right.
So he kind of standardized the technique of doing this transoral thyroid surgery. Before that, there were a lot of other remote access thyroidectomy procedures defined, which used to do from axilla, from
Right.
breast areolar tissue. So these are various remote access approaches. However, they are very far from the neck. You have lot of dissection to be done
Yes.
before you reach the neck region.
Mhm.
And for doing a bilateral, you will have to use both the sides of the area, and you will still
Yes.
put a cutaneous incision to approach that region.
Mhm.
The benefit in this thing is it's a midline incision, which is a mucosal incision. You make a
Right.
tunnel from the oral cavity and enter into the neck.
Mhm.
And being in midline, you can do on both the sides of the neck. So you can do a total thyroidectomy through the same approach. You don't have to go
Go
onto the
for
yes. You don't have to
exercise
open up.
other
So
side
that
of
is
it.
the major benefit with this. Secondly, this is being a mucosal incision. It heals very nicely without any appreciable mucosal cut also. So that is another benefit of this approach. Otherwise, so it started with mini incision in this region, which is towards the suprasternal notch, with an
Right.
endoscopic or video-assisted thyroidectomy, which was the first kind of a minimal invasive thyroid surgery process which was started.
Mhm.
Then from a cervical cut to an extra cervical location into the anterior axillary fold
Exercise.
or into the breast areolar tissue, that were the remote accesses. There was another approach which was devised, was a retroauricular approach, which I actually
Mhm.
started after my robotic training.
Okay.
But then the problem is there is a lot of hypertrophy of that scar after healing because of the lot of traction that happens. So I stopped
Mhm.
doing that thing. But from there, my journey started for scarless thyroid surgery. So retroauricular was behind the ear, that
Mhm.
we get the scar gets hidden within the hairline. So the concept is you are trying to approach the neck from different places except the neck, so that the scar remains hidden or invisible. But
Right.
the all remote accesses, they have a problem is the to reach that region you have maximum dissection to be done.
Right.
So so here, the only thing is like you extra doing is you are from the oral cavity, you are reaching into the neck through the anterior margin of the mandible. So you are trying to create the submental tunnel and extending into the sublatissimal plane. That is the extra dissection. Rest all neck dissection subplatysmal is same as we would do in a
Right.
open surgical
Open,
technique.
open.
Yeah. So only this part which is in the uppermost area,
Mhm.
that is only extra. So that is not more or maybe extensive as compared to the axillary or the breast tissue that we use for a remote access.
Right.
So the patient is prepared. We have kind of thoroughly washed. We are giving the thorough wash inside the oral cavity so
Mhm.
that the betadine gets washed out, and then we'll start with our initial process.
Okay.
Now, creating a tunnel is a thing that we won't be able to show you very clearly because
Okay.
there's a lot of blunt dissection in the initial phase. So
Mhm.
maybe if you can take a talk in between about
Okay.
the benefits and the process of transoral that we were discussing, so that by that time I will
Right.
just finish up with the tunnel making, and then it becomes a more of a interesting endoscopic picture, and then we'll start the surgery by that time.
Okay.
Is that fine?
Okay. So I will try to give sort of overview of this technique
Yes.
in my
Yes.
presentation.
So meantime, I'll just kind of do it quickly, make a
once you
tunnel
are,
and in the next space.
okay, once you are ready, then you can could just let us know,
Sure, sir.
and we will switch
Sure,
on to
sir. Sure,
session.
sure, sir. Thank you.
Nice.
माइक को थोड़ी बार बंद कर दो माइक ने खाली ऑफ
मेरी presentation हमारी presentation डेस्कटॉप पर चाहिए यहाँ से right. ना ત્યાં નહીં આપો અહીં બતાવવાનું ત્યાં દેખાતું તો વાંધો નથી એ કરી દે ને પેલું સ્લાઇડ શો યા ત્યાં સુધી કે ના એ અત્યારે નથી બતાવવાની અત્યારે મારી સ્લાઇડ છે ને જે પીપીટી એ બતાવવાની છે પછી જ્યારે કહેશે ત્યારે આપણે ત્યાં આવીશું ત્યાં સુધી તૈયારી કરશે એટલે પ્રેઝન્ટેશન આવે ને પાવરપોઈન્ટ લાવે છે ને બેટે slide.
Hello. Sir, you can see the
Ah,
view.
yes. Yes, yes, we can see.
Okay, na sir. Perfection.
Yeah, bilkul.
Okay, हाँ sir.
Actually, in transoral, there are two techniques. In one technique, they approach the thyroid through the floor of the mouth. And second is this vestibular approach. So in the vestibular approach, we will put in 3 incisions in the lower lip. Presentation. Oh, तो ये तो से क्या दिखा रहा है स्लाइड में So I will try to give you a sort of overview of this technique because it's relatively new technique, but it seems that it's the era of this minimal invasive surgeries. So before going to the topic, I will like to tell you some technical terms which are very frequently used in this endoscopic surgery. ये open कर दें ये तरह वो दे चलते
Sir, you need more zooming on the surgical side or it's okay?
Hello.
Good. થોડું વધારે zoom જોઈએ છે કે બરાબર છે સર?
ના બરાબર છે એટલે બરાબર છે.
Okay.
અત્યારે એ લોકોને હું થોડું ઓવરવ્યુ આપું છું અને પછી જ્યારે પણ સિદ્ધાર્થભાઈ કહેશે ત્યારે લઈ લઈશું પછી.
હા.
અહીંથી તો સ્લાઇડ વ્યૂ સ્લાઇડ શો સ્લાઇડ શોમાં નહીં સ્લાઇડ શો નથી દેખાય સ્લાઇડ શોનું ઉપરથી આવે છે बस इस slide को move करें। बस इस slide को move तो कर रहे हैं। आएगा। नहीं आता। ऊपर से आओ से। अच्छे। So main difference between this endoscopic surgery thyroidectomy and our conventional approach is the scar. So there will not be any scar in the neck. And particularly for some of the patients, ladies patients, female patients, is very important. So the main driving factor that developed this this endoscopic thyroidectomy is the cosmetic and aesthetic. Now there are two terms. One is the remote access, means we are not directly hitting to the thyroid. We are coming in the region of thyroid through some remote place. So remote places, as the Siddhartha Bhai mentioned, we can approach it through the axilla, we can approach through the sternum, we can approach through the breast, we can approach it to the retroauricular region, transsternal. So these, but in these techniques, the passage is quite long. Though we say it minimum invasive, it's not. It doesn't remain minimum invasive. Rather, it becomes maximum invasive, because in the traditional technique, we do not come to this axillary region. So this, and again, this transoral terms that we are using is that either we can approach the thyroid gland through the floor of the mouth, and the second, that is the better and safe technique is the we can approach the thyroid through the vestibule. So we are putting the incision in the inferior vestibule. So vestibule is the space that lies between the cheek mucosa, buccal mucosa, and the mandibulum. So if you go through that, that is little easy, and even distance also is short, and results also they are better than the remote access. So there is another term that we should know, and that is this notals. So this notal is natural orifice transluminal endoscopic surgery. So actually, when we are approaching the thyroid with a vestibular approach, so it becomes this natural orifice, because these lips and this oral cavity is the part of natural orifice, and through that natural orifice, we are approaching the thyroid. So any surgery that is done with this field, that is called natural orifice transluminal endoscopic surgery. Similarly, we can approach through even many other organs also. So the only advantage again that is it is highlighting the slide is highlighting is that in this technique there will not be any cervical scar, operative scar. So this is TO transoral endoscopic thyroidectomy with vestibular approach. In the traditional technique, when we are doing this thyroidectomy, so people they try to hide the scar that is in the lower part of the anterior part of the neck. So there are various methods with the help of which we can try to hide the scar. You can see quite a good number of methods they have been shown in this slide. Now the remote access thyroidectomy, so we can approach the thyroid from different distant regions.
Excuse me, sir.
Yes, please, Siddharth Bhai.
So here I have just created a subplatysmal tunnel, which is a blind procedure. What I wanted to show is like we have put this Veris needle, which is a CO2 insufflator needle,
Okay.
which is for the laparoscopic surgery into the subplatysmal neck.
Can you
Now-
show us this? Can you show us this needle and these different parts, Siddharth Bhai?
So this
you
is
show
the
the-
needle. This is actually for the CO2
Okay.
insufflation. And this is, here I'm injecting saline. So what is important for you to see is this.
Right.
Here you can see there will be saline, this hydrodissection. You can see the bulk that is happening here. And zoom kar jo. And zoom kar jo.
Do you, along with this normal saline you are using?
plain saline, normal
Plain,
saline.
plain. Okay, plain saline, normal saline. So do you mix this with the adrenaline or with is plain
Nothing, sir, only plain saline.
only plain saliva? Oh,
Just
sorry.
hydrodissection so
Saline.
that when we are inside, you will get easy planes to be dissected.
Okay, okay.
So that's the initial first step. Now you can continue with your talk, sir.
Okay, okay. ये कोणाला ले जा. गणपती मारू
10
आपले.
mm से 12, sir.
नहीं नहीं हाँ.
હું ઊભો થાઉં છું 1 મિનિટ.
Hello.
Hello. हाँ, sir.
And બસ એ proof બતાવું છું એ લોકોને PPT. તમે જ્યારે કહેશો ત્યારે પછી તમારી પાસે આવી જઈશ.
हाँ, sir.
So with the passage of time, this technique is becoming very popular, and specifically among the female patients, because they won't have any visible scar on the neck. So from the distant places, remote places from where we can come to the thyroid region, they are mentioned in this. बंद करना इधर. इधर बंद कर.
Okay.
So these are the remote places from where we can approach the thyroid region. So this is the sternal, transsternal, and they put incision on the breast also. You can see on the upper part of the breast. And this is the region of axilla. From there also we can come to the thyroid region. But the scar will be there, but the scar will be quite away from the neck.
Loose person.
And then again, this is technique. In this, you can see the 4 pores they are using.
Sir, garam
And
pani
with
le
this-
जाओ. Clean
And
करवा.
with this technique, we can approach the entire thyroid gland.
Right, balance कर लेते हैं.
And if we wish to perform total thyroidectomy, that we can do with this incision.
वो गरम पानी ले दो.
But
clean
again,
करवा.
you can understand that the distance is quite good. So it doesn't remain minimal invasive, rather it becomes maximally invasive. Now in this table, you can see the main differences between the traditional open approach and the minimally invasive. And this hospital stay, actually, it varies from person to surgeon and institute to institute. Some of the surgeons, they say that on the very next day after 48 hours, patient can go home. And some of the surgeons, they keep the patient for a little longer time.
Clean
So in
करो.
this approximate stay, that is again, is not is relative terms. Incision, that is important because the patient will not have any incision in the neck region. Recovery time also, it's more or less doesn't make much difference. Though in this slide, it's saying that it's prolonged and faster in minimally invasive. And complications also, they are more or less almost similar, but they are in the natural, traditional thyroidectomy. So this natural orifice transluminal endoscopic surgery, actually, this is our trans oral endoscopic. It is similar to this only, because we are not putting any skin incision here. So our incision will be put in the labial mucosa. So labial mucosa means we are using the natural orifice, mouth opening the natural orifice, and through which we are putting the incision. So this technique, trans oral, is a type of, you can say, the natural orifice transluminal endoscopic thyroidectomy. Now we can approach different areas to this transrectal, transvaginal, transnasal, but they are not right now the topic, but just to make you aware about the this natural orifice.
एक retractor ले.
So the main characteristic point of the remote access thyroidectomy there, it becomes maximally invasive, because for reaching that thyroid region, you'll have to pass through quite a good distance. And that's why it is not that much favorable approach. And it requires specific instruments, which requirements trans that is not this natural orifices. So they will need these specific instruments. And even the learning curve also will be longer, because from a distant place you'll have to come to the thyroid region. And in this technique, there is a scar on the skin, but that scar is not on the neck, but that is on the other parts of the body. So, and that other part of the body usually there is covered by the dust material.
Retractor. Retractor.
Now let us see some history regarding this transoral thyroidectomy. So this procedure is not that much old. So it was first described by in 2008 and 2009. And that first, that transoral I'm talking about, that was performed by this sublingual approach, or the floor of the mouth. But this floor of the mouth approach, that gives quite good chances of damaging the mental nerves. And if you wish to avoid, then we should go for this transoral with vestibular approach. So this first transoral thyroidectomy that you can see, that was devised to save the injury to the mental nerve. So if this mental nerve is injured during the surgical procedure, then patient will develop numbness and paresthesia around the lower lip and or the chin, because these mental branches, they will supply to the central part of the lower jaw and central part of the lower lip. This vestibular approach that right now Siddharth Bhai is going to show us, that was first reported in 2013 and 2014. Just 10 years back only. It's not that old technique. And in 2015 and 17, this trans robotic thyroidectomy that was done. So in this transoral vestibular approach, we put two incisions. They are vertical incisions, and they are of 5 millimeter length. And these two incisions laterally through these two lateral incisions, then that port that we use the 3 ports. So those lateral ports, they will be introduced in this. And that central incision in which that our scope will go through that port. So that will have the light carrier and the vision both. So this is another advantage of this technique, is that we can magnify the field. So once the magnification is there, then definitely we can appreciate the important structures well. Like when we are working very near to this recurrent laryngeal nerve, so at that time we can have good magnification, and that will help in saving the this recurrent laryngeal nerve. Now the eligibility criteria. Now again, this eligibility criteria, they are little relative, and they may vary from surgeon to surgeon, institute to institute, but usually the patient should have high motivation to avoid the scar, the cervical scar. So only those patients they should be taken for this technique. But the patients who are not much concerned about that, then in those we can go for our
Patient eligibility for
additional technique.
transoral thyroidectomy. Nalla slide.
Hello? Yes? Hello? Mayur bhai?
हेलो कैसी कट रही है हेलो
आवाज हो ना जल्दी पकड़ो ब्रदर आप पकड़ो स्कोप ने
हेलो
हाँ.
हेलो
Yes.
हाँ सर एनी क्वेश्चन
Should I continue my this presentation, or should we switch over to your that camera?
you sir continue your presentation sir will
Okay.
be get you soon
So whenever Siddharth bhai say that, again we will join you.
yes sir
Okay.
पकड़ो ब्रदर
Philip.
ત્યાં સુધી ક્લીન નહીં થાય ને ત્યાં સુધી અહીંયા દેખાશે ને ઇન્સ્ટ્રુમેન્ટ
So ideally for the beginners, we should have this extent of the disease should be very limited so that they can do better work. So there are certain favorable features. Favorable features means in these patients, the surgery become little easy and short one and give better result. It's not that difficult. So these favorable features is the patient's own motivation that I mentioned in earlier slide also. And then these benign nodules, they should be 6 to 10 centimeter size. And cytologically, Bethesda category 3 or 4 that we can take. And in the estimated thyroid diameter, 10 centimeter on the ultrasound. So that we can multiply these 3 dimensions and then we can know the volume. So what they say that up to 45 ml, that's okay, that we can do in these patients. And then if the patient is having Hashimoto thyroiditis, so at the time of active disease, patient will have little hyperthyroidism. But with the passage of time, again the patient will become the euthyroid, and ultimately they end up in the hypothyroid. So the symptomatic Hashimoto thyroiditis is it's not a good favorable factor. Then if the patient is having carcinoma, differentiated thyroid carcinoma, and if it is about only 3 up to the 3 centimeter size, again that can be very easily approached with this transoral approach. You can perform this surgery. But if it's bigger than that, and it will literally, then again, as I told you that it will vary from surgeon to surgeon. If the surgeon is very experienced, they can even go for safely, they go for even total thyroidectomy also. And the favorable means in this, again, the procedure will become a little difficult. And the results, they may not be that good as they were in the favorable features. So this substernal goiter, you can call it a retrosternal goiter. So if it is approaching towards this superior mediastinum, again, these will be challenging cases. In the previous neck and chin surgery, again, that way we can understand that will lead to fibrosis. And again, the surgical steps, they will be difficult. Or if the patient is having previous neck radiation, so due to that radiation, again, there will be a lot of fibrosis and the skin also become very sort of fixed sort of skin. So again, the procedure will become very difficult. So for the initial surgeons, these patients, they should be avoided. They should not be taken for surgery. Then there are certain preoperative preparations that we saw. Dr. Mayurbai showed us this position of the patient. So patient is kept in the supine position. But before entering into the OT, patient should use this chlorhexidine mouth rinse. And then, as I told you, that the patient will lie in the supine position. And then we'll get its neck extended, neck in the hyperextension. So we can put a rolled sort of sheet under the shoulders. And if need be, just below the occipitum, you can put the ring so that it will help in keeping the patient in extended and center position. So this technique is always done under general anesthesia, and usually we request to the anesthetists that they go for this nasotracheal intubation. Because nasotracheal intubation, it will be easy because in the mouth oral cavity, we will be using these 3 ports, so there will not be any much space for the orotracheal intubation. In the surgeon's positions head with a full view, oral cavity. So the surgeon will sit on the head side of the patient and monitor should be toward the lower limb of the patient. There's more or less, you can say it's like this tonsillar position. So in that patient will lie. Then the surgeon will definitely sit on the head and side, and just lateral to the surgeons, the assistants, they can position themselves, they can stand, they can help. So one on each side, if need be, then we can have the 2 assistants. Then when we are painting this upper chest, neck, and lower face, they are prepped with the iodine solution. We are using betadine. So that betadine should be used almost from the lower lip, and it actually go up to the areola of the breast. So that much area which should be. Then drape is placed over the upper face. Extra drapes if needed, they can also be put, and they can keep these instruments. And if need be, and if they are facility for the nerve monitor, again that will try to help us in saving the nerves. So in the lower part of the vestibule of the mouth, or inside of the, you can say the inside of the lower lip, we put 3 incisions. And through these incisions, our that port, they will enter.
Right.
The 2 lateral incisions, they are of 5 millimeter length, and these incisions, lateral incisions, they are vertical. In the central, we use 10 mm, usually 10 mm transfers centrally, just opposite to the central incisor teeth that we put in the lower lip. It should be little above the frenulum. So the central port will have the around 10 millimeter size, and 2 lateral ports, they will have the 5 mm size. So there are main scope that will go through the center port. So the center port scope will provide us the view and bright light to the patient. And 2 lateral, those 5 mm ports, they will be introduced in the lateral. And with these lateral, we can use suction, we can use any cauterization, we can pass on any forceps and all those things that we can do. Then prior to the port placement, a working space is created. So right now, Dr. Siddharth Bhai, he was working on this, developing on working space. And that is not sort of monotonous, and that takes time. That's why he's just told us that better you have some overview, and then we will come again to the Dr. Siddharth. And the Kelly clamp that again dissect and create a tunnel through chin until the submandibular area. Now these are the diagrams you can see very easily. So these are the in the we will be making incision. This is the central incision that is transverse and just anterior to this frenulum, and 2 lateral incision you can see. They are of 5 mm length, and they lie just lateral to the canine teeth. Through these we will enter the smaller those ports for 5 mm size. So these are the different ports. This is the central port, and these are the 2 lateral ports. And you can see on the position of the neck also in this. Again, you can see these 3 ports that have been introduced, and in the center port, you can see the scope that will come. So it is providing the bright light and as well as magnification and total clear view. You can see this. So in this technique also, you can actually, and this we would use only 30-degree camera actually. It's not the 0-degree, this endoscope, there are 30-degree that is used for this neck surgery. So the scope will remain little anteriorly, and if it would show the vision that we have during our traditional thyroidectomy. Let us see the flaps in the working plane. So this subplatysmal flap. So if you in our normal routine traditional thyroidectomy, we use this flap only, subplatysmal. So in this endoscopic also step, they are more or less similar to the traditional one, but the main difference that is the view is the little different. But otherwise, so just to have this good subplatysmal flap, what we do, we inject roughly about 500 cc of normal saline. Some people, they mix it with the epinephrine, adrenaline, and some they like the Siddharth Bhai, he doesn't use the epinephrine, so he uses only the 500 ml normal saline. Then with this help of this needle, varicose needle, so it will advance and flap that we will elevate up to the suprasternal notch. And once the central part is done, then that needle is moved laterally. So the lateral limit will be this sternocleidomastoid muscle, that is the lateral limit. And then this subplatysmal flap, as I was saying, it's a blunt dilator. And these are the 2 that I told you, the 2 ports. They are like laterally and one in the central position. And when we are creating this flap, we should try to avoid the penetration of the skin over the symphysis menti, because this is the most prominent part of the lower jaw. So there are the chances of piercing the skin, they are very high. So at that side, we'll be very, very careful. We should not lead to through and through skin, that sort of perforation. Then CO2 insufflation that we will use, the pressure that is kept is about 6 millimeter of mercury. And then we introduce the 30 degree, as I told you, through the central port. We will introduce this 30-degree scope,
બેસી જાઓ એટલે નીચે થઈ જશે.
and through the lateral, these 5 smaller ports, they are placed two lateral incisions. And then a Maryland dissector and bipolar ultrasonic energy that is used while we are making the flap. So the main steps that you can see, that the dissection that we'll have to dissect, mix, and we will learn to develop this subplatysmal flap and subplatysmal space. So I was telling the inferior lateral limit will be sternocleidomastoid. Then the step muscles, as we do in our traditional, they are divided in the midline to expose the thyroid gland. So the step muscles, when we will retract it laterally, it will give us the complete view of the anterior surface of the thyroid gland. And if need be, at that time only, we can divide the isthmus. In the ligation of the vessels, now there are two main arteries. One is the superior thyroid artery and the inferior thyroid artery. So they supply to the this thyroid gland. And superior thyroid artery is the branch of external carotid artery, and the inferior thyroid artery is the branch of thyrocervical trunk, which itself is the branch of subclavian artery. So we should know this anatomy of these vessels, because the nerves which is supplied to the larynx, they run very close to these vessels. And Siddharth bhai,
Yes, sir.
can you tell us when you are this
10 minutes,
line-
10 minutes, 10 minutes more.
Okay. So we will ask that Siddharth bhai will tell us what landmarks that we use when we are ligating this superior thyroid artery and inferior thyroid artery. So what landmarks we use? The landmarks which we use for doing traditional are this Beer's triangle and Dole's triangle. So whether they are important in this endoscopic approach, actually I'm not aware. So that Dr. Siddharth, that he will tell us. And we have the nerve monitor, and again definitely we can save these nerves better. Then inferior thyroid vessels, that also we'll have to ligate. When we are saying vessels, means both artery as well as vein, that will have to die. And then the parathyroid glands, again they should be preserved as far as with their blood supply. They should not disturb, otherwise in the postoperative phase, patient will develop hypoparathyroidism. And similarly, we can approach the lateral lobe. And once we have cut the thyroid gland, the excised part, that we can bring into the endo catch bag. And that specimen will come into the endo catch bag. And that endo catch bag is taken out through that central port. So that is the largest one. And Bailey's ligament is very important, because this recurrent laryngeal nerve, it crosses this and then it will enter into the thyroid gland. Then after removing that excising the part of this thyroid gland, we'll have to close the wound. And they are closed in first layer will be the step muscles. First we'll approximate, and that in that we can use the 3-0 vicryl. And then the instruments, the ports, they are removed. And after taking out the instruments, the midline incision that will be closed. And midline incision that is closed in 2 layers. And one layer is of the mandibular muscle, another one will be the mucosa. So for that we can use 5-0 chromic suture. And then after closing, we are not using this technique. We are not using any drain. So without drain, when we are not using drain, we will have to go for this pressure dressing placed on the neck. So that will not allow the flap to get raised, and that will maintain the negative. There will not be a negative space. So it is a very, very important one, this pressure dressing. Because it is not pressure dressing, little oozing, if it is there, that can lead to hematoma formation and seroma formations. So again, this discharge, again, that will depend from surgeon to surgeon. Some of the surgeons, they give discharge to their patients on the very next day or after 48 hours, and some they may keep more than a week or so. So that will vary from surgeon to surgeon. And what literature says, it says that 2 days to some of the people, some of the doctors, they're keeping the patient for 20 days. So the main advantage, if you see, of this endoscopic technique is that it is providing us the magnified views. And this magnified view will help us in saving this recurrent laryngeal nerve and the external laryngeal nerve, that is the branch of superior laryngeal nerve. So these nerves, they can be saved. Then we can identify the parathyroid glands also very quickly. And it will facilitate the clearance of the central lymph node dissection. If you are going for that, if the patient is having carcinoma, then we'll have to go for the central lymph node dissection. So that again we can perform with this technique. In the reduced surgical space, so narrow triangular, this instrument that they will limit the maneuverability. So that is the sort of disadvantage. And the patient and the surgeon should be trained by the endocrinologist as well as the laparoscopic surgery, because here we are using the thyroid area, so that anatomy should be very clear. But the basic principles of this endoscopic that can be learned when we are performing the laparoscopic surgery. Then these various type of thyroidectomies are there, and almost all these thyroidectomy, they can be performed with the help of this endoscope, like this isthmusectomies, lobectomies, subtotal thyroidectomy, completion thyroidectomy, and total thyroidectomy. So this completion thyroidectomy, that is done in cases of usually CA, carcinoma. So initially patient, when we submit this specimen to the histopathology, at that time we come to know that the patient is having carcinoma. So in those patients, whatever part of the thyroid is remained behind, so that we remove, and that's why it is called completion thyroidectomy. And the patients, if you see, most of the patients, they are benign symptomatic disease, and they don't have any evidence of malignancy. They can be nodule. So their patient will have only nodules of the pathology category 2 to 4. And the conversion to an open procedure. These patients are very few, in which if there is quite excessive bleeding is there, and an underestimated size of the goiter, and if the goiter is extending into the retrosternal region, then in these cases, we'll have to go for this conversion. Conversion means we are giving up that endoscopic sinus surgery, and we'll be performing the surgery with the help of our traditional technique.
There is the hook. Okay.
In the
So, sir,
post-operative care, again, yes, Siddharth bhai, ready?
we have entered the next phase. You can see both the instruments.
Okay,
And we are, I'm sorry for little bit fogging is there. It will be just cleared in some time.
okay,
I'm trying to dissect the subplatysmal flap anterior to
Right.
the strap.
good.
So now because of the hydrodissection, which was
Yes,
done in the shape, it becomes an easy job at this time.
right.
खाली message ले लो. अगर टच कर तो अंदर टच करो, टच कर. उबारो कई बात नहीं, चलिए करिए दइए थोड़ा.
Siddharth bhai, will you a little oriented with the image, which is
Sorry?
side is anterior? We are not getting orientation of the image. So can you just show us the different means
No,
this is the
sorry.
anterior part, which is posterior, so that we can appreciate.
I'll orient. I will orient. Just a minute.
So
Pin
right now
करना.
it is too focused, too magnified.
Yeah. So we are trying to clear the camera so that you can see it properly.
Okay, okay.
તો કીધું ફોન ઉપર એમને કનેક્ટ કરી દે, કોલ બેક કરે.
So
Call-
these are central.
Go in. Go in. Yeah. 19. One second. Instrument can do. Instrument can. नहीं छोड़ दो एक मिनट. ट्रैक का तो ये क्या है.
How you inject this normal saline, Siddharth bhai? Whether you inject through the oral cavity or outside skin, cervical skin.
No, the infiltration was done through the subplatysmal tunnel which was created from the vestibule.
Okay, okay.
થોડું ક્લીન થઈ શકે એવું છે. એક કામ કરવાનું એક છે ને સલાઈન પાઇન્ટ લઈ લો અહીંયા વિથ પ્રેશર અને એને સક્શન સાથે કનેક્ટ કરી દઈએ ઇરિગેશન માટે. 1 liter લઈ લેજો.
And just you show the
So
instruments.
here I'm dissecting right now towards the suprasternal notch.
Suprasternal notch. So you reach up to suprasternal notch.
So I am heading towards suprasternal notch.
Okay,
I'm in midline,
right.
separating the subplatysmal flap. नहीं पाछળ नहीं આવતો.
Okay,
Separating the subplatysmal flap.
right.
Yeah.
Can you just show us some landmarks through which you can decide that you are working in the ideal subplatysmal space?
Sir, whenever we enter the neck,
Yes.
you can see that there is a loose areolar tissue between the muscle, I mean the tissue here and there.
Okay,
So this is the platysmal muscle.
right. So it will be deeper to the platysmal muscle.
Yeah, I am deep to the platysma muscle.
Yes.
બહુ ગંદુ છે, ક્લીન કરવું પડશે.
And what are your lateral limits? Inferior limit is the
That
suprasternal
limit
notch.
is the sternocleidomastoid muscle on either side.
Okay, right.
So important thing is that the exposure is good, so then the working space created is good.
Right.
We want to make it more wider in exposure so that the instrumentation is possible.
Right.
Clean, please. Now the initial plane making, the space creating process is a bit timing consuming because the instrument has to reach to the neck in the correct plane, and then you
Right.
start separating creating the subplatysmal plane. The more you clear, the more you
Right.
open, the space keeps on widening because there is a constant CO2 insufflation going on.
Okay.
Now you can see it much clearer than earlier.
Yes, yes.
Go there. Yes, perfect. Perfect.
We will appreciate if you can just show us instruments
Yeah.
also.
These are the midline strap
Right now
muscles,
you're-
the anterior strap muscles. This is probably the midline, the
okay.
median rupture between the strap muscles.
Okay. So the sternohyoid first.
Yes, yes. Now, still we need to open up a bit of more space so that this entire area will open up.
Okay.
There is a small oozing here you can see that we'll have to control.
Okay.
પેલું આપોને.
So this bleeding that must be using cautery diathermy.
Yeah, we have to control this bleeding.
Right. What is the name of this instrument? This looks like that sort of hook.
This is a
Space.
hook cautery
Hook cautery. Okay.
that is used by. So these are standard laparoscopic instruments which are used by the general surgeons. There is
you'd like to-
nothing specific or nothing different than a standard laparoscopic instrumentation set.
Okay. Now we'll
We use
appreciate.
all the instruments that are being used by the surgeon.
Okay.
As an ENT, we are never exposed to laparoscopy instruments.
Yes.
So initial period of orienting yourself for instrumentation is a bit of challenge. Otherwise, with time, you get an hang on it.
Right.
You have to make sure that you do not leave behind major vessel or maybe main vein bleeding.
Right.
Because
Okay.
there is a risk of CO2 embolization. There is a constant CO2 which is being pushed
Okay. Yes.
inside,
Yeah.
and
Right.
these
Right.
open
Right.
veins, they tend to carry the CO2.
Mhm.
So you have to keep informing your clean. Please, તમે ધ્યાન અહીંયા રાખો. અને પછી ફોન કરશે. Urgent ના હોય તો. So we have to ensure that there is no CO2 embolization. So anesthetist needs to be informed to check on the heart rate and blood pressure.
Right. So patient develop tachycardia if that CO2 is little absorbed, or bradycardia.
So I'll leave that question to answer by the anesthetist. How will they make out that the patient has developed CO2 embolization? Anybody from the anesthesia can take up the. हाँ, आप ही दो.
So this is the loose that irregular tissue you're talking about.
Yeah, so this is the loose areolar tissue. You can see the plane which has been created. This is very easier to separate because of the hydrodissection which was done earlier.
Okay. Can you show us the Mendelis also? If it is coming in your view, definitely.
What? Can you repeat the question?
Mendelis muscle.
Sir, we are beyond that because the trocar is in that region. So we will not
Okay.
be able to show you right now
Right.
because trocar is in that region.
Okay.
The
Little trocar, little.
the middle trocar through which the camera is placed is in the
Right.
midline.
Yes. And that is of 10 millimeter size.
10 mm port, yeah, that is the 10 mm size.
About the later is, I think, is
They are 5 mm. Lateral
5
ports are 5 mm for the instruments.
Yes.
So right now my Maryland is on the left side and my hook cautery is on the right side, and I am slowly creating the space and plane.
What is this Maryland?
That's this instrument is Maryland.
Okay. Okay.
So that is an holding instrument
Mm-hmm.
and dissecting also. You use this for dissection.
Okay. And you can hold even bleeder also with this.
I'm sorry.
If there is any bleeder, that can also be picked up by this forceps,
So
Maryland.
get bipolar connections along with it, so you can bipolarize also
Okay.
using this instrument. So now I'm giving a counter traction on the tissue downside and separating the loose areolar tissue with the cautery. So
Okay.
that helps me create the working space. Go in
Mhm.
a bit. Go in. Yes. So now I am reaching more closer to my inferior limit. So you can see this is the vein.
Mhm.
This is a vein. Can see?
Mhm.
That's the anterior jugular vein that we see in the midline.
Okay.
So you have to stay close to it stay close to it so that it doesn't get damaged. Try not to damage it.
I think they lie at the subplatysmal level only, superficial to the stap muscles.
Yes, they are in the constant position here. You can have various venous malformations in the neck.
Yes, yes. Very common.
Now the only difference here is I'm working from a distance. In our
Right.
conventional thing, you are very close to the tissue.
I think
So
this stap muscle, they are visible. These are stap muscles only.
So these are the steps.
Yeah. Steps, yes, yeah.
To the step muscle. In our open surgery, you are quite close to the structure. Here I am at least around almost 20 centimeters away from working from a 20 centimeter away distance.
Right, right. It's more
So
challenging.
it's like when we do an MLS, you have lot of tremors that can happen to your hands because you are working with an instrument which is far off and the tip of that instrument is very small. So you
Yeah.
have lot of tremors which are kind of seen at the end of the instrumentation tip while
Right.
doing an MLS. Similarly, here I am doing working from a very distant, and so there will be tremors which will be seen.
Right.
Now, to avoid those tremors, the technique nowadays which is coming up is doing a transoral thyroid robotic.
Right.
The same procedure using a robo,
Okay.
and
Please
that
follow.
eliminates all the tremors that you can feel right now that you can see in your screen. The
Okay.
more magnification, the more tremors will be magnified, amplified. So I'm slowly kind of separating this layers
Right.
and reaching up to this my inferior limit.
Suprasternal nodes.
Yeah. Now that helps me in two important things is most importantly I will be able to see the trachea here there
Mhm.
in midline. So
Okay.
that will help me to define my midline.
Right.
And my trachea is my very important landmark when I'm doing this surgery
Mhm.
because my isthmus can be approached through that. I know where my isthmus would be in which direction. So keep in, go in, go in, in. Yeah, thank you.
So what anatomical landmarks you use to save recurrent laryngeal and superior laryngeal?
In this case, we don't routinely see superior laryngeal in like we see in Thunderbird, like we see in our open conventional procedures.
Right.
Pardon?
So what is the main difference between identifying this?
So the recurrent here will be seen at a different stage than open surgery. In open surgery, you see the recurrent towards the end when you are kind of going for the lower pole,
Okay.
or in certain people, they will go for the superior pole, then look for the. एक second, I'll just control this bleeder.
Okay.
Nah. Action after બીજા હાથમાં. બહુ ટાઈટ છે બધું લૂઝ કરો ને. એક મિનિટ હમણાં. ઓકે ઓન. The line is on. So I'm kind of irrigating right now so that the blood is cleaned. The planes are cleared. Pressure bag लगाई दो ना एना ऊपर. There is a small bleeder still here. Okay. The midline.
तुमने कोई क्वेश्चन पूछ सकते हो?
Pop type. Close pop था sir. The in bleeder saline चालू किया.
Yes, Siddharth bhai.
Yeah. So here, because it's a narrow neck space,
Okay,
these energy devices will give a lot of fogging to the lens.
right.
So, at in between you keep saline बंद रख दो.
So which this energy device you are using, Siddharth bhai?
I'm sorry, sir, Faridi.
Nee,
So
you are talking about
in my hospital, I use harmonic.
harmonic, yeah, good.
I'm sorry, I use Ligasure.
The harmonic we have, I think they can, if you say they can provide you in the OT. Harmonic they have here.
Sorry.
Harmonic, I think that we have in the OT.
Yeah, sir.
So-
But the only problem with harmonic is the instruments, the tip is very straight.
Okay,
You need a bit of curved
Curved.
tip for deflection also.
right, okay,
So that's why you prefer sealer,
right.
because it has a curved tip.
So the sealer, which energy they use? Sealers, which sort of energy they use? What is the basic principle, what I meant to say?
So it basically seals the vessel as well as cuts. It's like a thunderbit only what we have right now, but the mechanism is different. That's an electrical this thing, and this is ultrasound based.
Okay.
So it generate, there is an active blade here, which
Mhm,
will kind of burn the tissue and cut.
right.
While in the Ligasure, it's basically
Yes.
like a cotton. But
It's like a
that,
cotton.
yeah, so it has a Teflon covering on both the blade. Here in this case, there is one is active blade and one is inactive blade.
Mhm,
So in that, both are active. So you have Teflon coating on both the blades in the sealer. So it
Sealer, okay.
basically, yeah, it basically seals the vessels completely.
So can you just tell us
Then you have
about the
option there.
can you tell us about the size of the vessels or artery that it can seal? 2 millimeter, 3 millimeter, 4 millimeter diameter. Up to what size of this vessels they can seal?
The size of the vessels that it can seal.
Yes.
Sir, generally whatever I think it is up to 5 millimeters that is possible.
Okay. Again, 5 millimeter quite a big size. That
We don't
definitely
encounter bigger than that for our thyroid. So for
Yeah.
us, It's not
It's
a
a-
major concern. So now we are in the midline. Camera सीधा
Right.
रखो.
And then you will
Straight.
separate these two side step muscles. You can separate from
Yeah, I
here.
will do that now. So I feel that this is our midline. This area is our midline.
Okay,
So now I'm going into the midline.
right.
ઉપર ceiling છે ને નીચેનું cutting છે.
Fogging થાય છે, fogging થાય છે.
ઉપર ceiling cut છે. Okay. I'm using this thunder bit for the, I mean, very first time for thyroid.
Okay,
So bit of training for myself to use this.
right. Then just tell us your comments whether this is better or what you were using that was better.
No, sir, both are good. Only thing is I'm more used to the previous one
Okay, right, right, right.
because we don't have thunder bit at our place.
Okay. નામ પણ કેવું છે થંડર નામ છે થંડર કેવું મુકજ નામ
Uh,
નામ જોઈને એવું લાગે શું થંડર કરશે.
So here we are trying to go in. So we are trying to stay in midline.
Okay,
So that some point of time I will see the trachea and that will help me to identify my midline.
right.
Fog થાય ને ધુમાડો થાય ને ત્યારે થોડુંક પાછળ આવી જાવ so that એ નીકળી જાય અને પછી પાછા in.
So quite good number of great vessels they come in the suprasternal region. So would you like to stay a little away from the
You have
suprasternal?
to be very careful in that region, sir. So
Yeah.
nothing should be cut without knowing what you are cutting,
Yes,
because this is some place where you don't have control. If there is something mishap happens, you have to open up.
right, right.
And I have encountered such issues in my practice. So in that case, you
I think-
will have to open up to control the bleeder.
I think this conversion rate is not that high. Literature says less than quite even less than 1%.
Sorry, sir.
This conversion rate, is it common?
It is less, but it all depends upon your patient selection. I mean, in my earlier practice, because I was getting trained by my own self, I didn't had any formal training for it.
Oh, so great.
So
That's
then the
great.
case selection would matter. I may take something which is not a feasible case.
Hmm.
મને પેલું આપી દો ને grass પર. And in that case, we might land up doing a open conversion. So what I have realized from my experience of 35 cases,
Hmm.
that male patients are a bit difficult to operate because
Right.
of the prominence of the laryngeal cartilage,
Okay.
and you
But
struggle them. Clean करो ऊपर से scope.
that is
They have a
more
lot of
common in-
prominence. So the instrument will kind of be difficult to maneuver inside the
Maneuver.
neck because of the
Okay.
prominence. So those cases in my earlier days, wherever I have taken for male patient, I have to kind of convert some time into
Hmm.
open.
Right.
So those was एक मिनट ऊपर काफी ना किया. So those was my challenge in the earlier days.
Right. And as you told earlier, I think this learning curve is little more long in case of remote approaches in comparison to your
Yeah,
this.
so more and more,
That's how it
I
is.
mean, for this approach, probably around 10 to 15 cases is the learning curve going.
Right.
Yeah. Stay in
For this
midline.
transoral vestibular approach.
Yeah, sir. Okay. So I'm trying to separate the strap muscles in midline on
Okay.
either side. Back, come back, back. Ah, okay. પાછું.
That white raphe, that's not that commonly visible. That lies just exactly in the center of midline of these step muscles.
Sir, because of the nodule, you might get the midline shifted at
Okay.
times.
Right.
So the earlier time when I showed you, that was supposedly midline. So I'm going through that plane only.
Okay.
the white line, and there is a bit of uh, the tissues are kind of soaked with a bit of blood,
Yeah,
and that's why you are not able to see it very clearly.
right.
So this is somewhere in midline that I'm trying to open up.
Mhm.
Go in, please. Take a minute. Okay. Go in. Center. Midline. Midline. Midline, Rapo. Yes. Go in. 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 Yes. Stay in midline. So you see, I have kind of tried to separate the strap muscles on one side to open up. So you can see there is a nodule which is seeing underlying here.
Yeah, yeah, yes, yes, we can appreciate, yes. This swollen part, it is showing that only.
Yeah.
So upper limit of the separation is the lower border of this your thyroid cartilage. Superiorly, where what is the
Superiorly, you should be, yeah, you should be up to thyroid cartilage so that you can take pyramidal lobe.
right?
Around, thoda. Upar, upar, pacha. Right. Yes. So I am going superiorly now.
Right. And just beneath this, I think will lie the isthmus of the thyroid.
Yes. Oh, oh, oh.
How much the BP, Siddharth bhai, Ashish bhai?
So
How
we
much
have tried to keep it up around 100.
Okay, because the area is quite dry actually. Totally almost.
That's the beauty of anesthetist.
That is the beauty of surgeon. Anesthetist both.
Sir, I will bleed, but then if the pressure is lower, it will not appreciate at bleeding.
Yes, yes,
So I
yes.
will give full credit to my anesthetist who is very efficiently able to do this.
Now in that way, Ashish is very efficient.
Okay. So
जैन साहब कुछ बोल रहे हैं।
So the initial part in this surgery, I mean, it's in a way a bit of longer duration than a normal conventional open surgery. I mean,
Right.
somebody would be getting frustrated saying, "What is all this? You can finish it off in half an hour."
Okay.
But it's all about being patient to give something in return to the
Ah.
patient.
Right.
So the time should not be a factor for as a surgeon.
Yes.
So something, whatever is minimal invasive is going to be a time consuming because you are going in that plane which is not a natural route for that surgery.
Yes. So ideally, these surgeries they should not be called minimum energy because in this the dissection is too much. So it becomes rather maximal invasive.
Yes, sir.
Because our traditional open technique, we do not dissect that much.
Yes, we do not dissect normally, but we obviously do midline strap muscle dissection.
Yes, yes, yes.
So the word minimally invasive is in terms of the incision.
Yes. But
So through a
inside,
small hole incision, you are entering and doing the job
yes.
of doing the entire surgery.
Another term they are using this natural orifice transluminal endoscopic surgery.
So the transluminal is a lumen. Through a lumen, you are entering and doing the procedure.
Actually,
No, no, brother.
in a sense, our this technique also is natural orifice because we are approaching the thyroid gland through the mouth. That is a natural orifice.
Yes, that's a natural orifice. So you have, we do nasal endoscopic surgery. That is a natural orifice.
Yeah,
Nose is a natural orifice.
Yes.
So here I have kind of been in identified the nodule. This you can see the nodule which is
Yes, we can
here.
see.
This is the nodule.
Yes.
So we are trying to go beyond the nodule in the midline so that I identify the trachea.
Okay.
પાછળ આવી જાવ થોડા ફોગ થાય ને એટલે પાછળ આવી જવાનું એટલે ક્લીન થઈ જશે જલ્દી. Yes. Go in now. So that's my suprasternal area.
This right now, this whitish thing that we have, that is the fatty
I am
parts.
here feeling trachea. I will show you tracheal rings.
Okay.
I can feel trachea with my instrument.
You can feel, right?
The fogging that happens is a bit of concern because it keeps, there is no outlet channel.
Okay.
So unless that gas is out, because there is a constant turnover between CO2 incoming and outgoing.
Can we use the suction so that it will clear the, it will suck
So
this?
then it will keep, so if you keep the suction inside, the field
Yeah.
will remain collapse. The CO2 will get suctioned
I
out.
got
So
it.
they'll,
Yes.
so
Yes.
it won't be clean, please.
I got, yeah.
So we won't have that working space continue. So CO2 insufflation allows you for a constant working space.
Right.
Right now, the CO2 insufflation pressure that we have kept is around 6 millimeters of mercury, mmHg, and the flow rate should be around 10. So a bit of high flow rate, but a pressure that is the force that the amount of CO2 that enters the body is around 6 liters.
Mhm. Then you retract the step muscle so that you can have better view of the.
People, yeah, so there is a technique wherein from an external neck you pass a suture material around the strap muscles and you
Okay,
can put it like this so that it
Okay.
retracts the muscle.
Right.
Now this is once I have kind of dissected the entire lobe, I know the strap, I dissected underneath the strap muscles, then only I do, or we
Okay.
can do, because right now it is too early.
Right. Right. I got.
So she has a nodule right now more on the right side, but she has a little bit of bulkiness on the left thyroid nodule as well, on the left thyroid, which was clinically seen as a bulge.
I think in the USG report they mentioned that.
Is it shown? We are proceeding only for a right
Okay.
thyroid, but
Right.
she has a bit of bulkiness on the left thyroid
Left
as
side
well.
of-
Yeah. So it is first thing is to identify the isthmus. That is the most important part.
Right.
So as a surgeon and as a delegate, we need to be patient about me reaching there.
Okay. I think once we separate and retract these step muscles,
Yeah.
then
Yeah.
it will provide a better view of the isthmus.
So then one more important thing is you can keep a midline here in the neck. I mean, from the anterior neck, you can pass a stitch
Okay.
so that the center portion also remains retracted,
Mhm.
so that you don't hit it every time when you put the scope in.
Right.
Now, this is the trachea part, the which is kind of pushed
Pushed literally.
on the left side.
Okay.
So you can see this nodule here.
So we can see the little sometimes fullness sort of thing.
Yeah, I'll show you it clearly. Go in. Go
That's
in. Yeah. So this is the thyroid nodule. Will separate the strap muscles laterally overlying the nodule.
Mm.
So both the hands have to be equally active, be active. Go in. Yeah. Good. You can see the nodule which is being kind of getting defined.
Yes, yes.
Go in. So this is the strap muscle
Right.
which I'm, and we are kind of separating the nodule from
Mm.
it, from the loose alveolar tissue. So it's like dissecting it out, like blind dissection. I mean, blunt dissection, and then creating the space.
Right.
So first and foremost is kind of separating or creating space from all around the thyroid nodule, so that your holding to the nodule becomes easier.
Mm.
So you can see going. Yeah. This is the lower portion, lower pole of the thyroid nodule here. The nodule ends here. You can see
Mm.
this space.
Lower portion.
Yeah, the lower portion of the thyroid nodule. Is it seen?
Yes.
That is the lower. So
Okay.
somewhere here is our midline, and I have to kind of identify the isthmus.
Mm.
So whatever I'm right now feeling here is the tracheal ring. This is the tracheal ring region.
We can't appreciate actually from here.
I'll show you, sir. Once I'll dissect in midline. I'll
Okay.
show you the tracheal ring.
Right. I think you should also publish your work. 35 cases you are saying that you have done.
Sir, I published my 25 cases recently last year.
Okay, okay. Then it's
So
fine.
it's already in my first experience of 25 cases I have published.
Good.
And now I have done 35 almost. And
Okay.
that includes couple of parathyroid lesions also.
Oh, good. Otherwise,
So for
usually what this
parathyroid adenoma also we can use the similar approach. Now this
right.
becomes very handy when it is an ectopic parathyroid adenoma, when it is somewhere into the superior mediastinum
Right.
or it's somewhere paratracheally into the superior mediastinum. So in this, it becomes easy to look for it.
Mhm. Some of the surgeons, they feel that this for especially for this parathyroid, that open traditional technique that is good.
Yes, sir. I mean, it's how you are comfortable for anything.
Yes, definitely.
It all depends how much you want to kind of struggle for a case.
Right, right, right.
I mean, for this, something to give to the patient as a benefit, we are in a way kind of struggling ourselves.
True.
So here I'm trying to peel off, remove the pyramidal lobe,
Right.
which I'll show you right now. Go in. Go in. नहीं जरूर पड़े चलता है.
This pyramidal lobe, I think, is not that rare, but in good number of patients we see that.
Sorry, sir.
The pyramidal lobe, it's not that rare. In quite a good number of the patients we see that.
I just forgot the incidents, but it is, I think, almost 30% cases you see the pyramidal lobe.
30%, okay.
Almost 30% cases you see the pyramidal lobe.
Mhm. At your place in Zydus, how much this surgery will cost, sir?
Sir, this surgery at our place will cost close to 2.
Close to 2.
Yes.
Okay. So that include and that all
Everything,
the-
but if there is a patient takes a private category room, then it will go up to 2.5 or 2.25.
Okay, okay. And what about these insurance people, this Mediclaim, they will sanction it or they will say that it's a
Yes,
cosmetic surgery?
Yes, it gets claimed. I mean, it's a laparoscopic procedure.
Okay,
So laparoscopy is not an issue. Robotics still difficult to get the claim because
right.
not all procedures they are covered under. अच्छा नहीं loose છે. Move not થતું એટલું easily. खुली गયું છે? જોવો તો. Okay, thank you.
Now the patient's concern is only cosmetic and the euthyroid small nodule. So do these people, the insurance companies, so they say that you have been performing this surgery for these cosmetic reasons.
Yeah, that could be an issue.
Yes. So
But sir, thyroid surgery is a defined procedure. So probably
that is
insurance companies have never argued about that being a cosmetic procedure. So
because
you
usually,
do an ultrasound, you do an FNSE,
right.
and the pathologists are also very friendly with us. They will give Bethesda 3 and 4.
Okay.
क्या मैं देखा तो?
No, what I mean is Mediclaim, this insurance companies and this corporate hospital, they have some tie-up, and you already have quoted the cost of thyroidectomy. Say it will be like it will be that much, and then if you go for this endoscopic, then that
Good.
cost will go up. So do they object to that?
સર ગ્રેજ્યુઅલી બધું આવશે પણ કેપિંગ તો આવવાનું જ છે બધામાં.
હા એ જ કહું છું એટલે કેપિંગ તમે એકવાર રેટ તમે તમારે આપી દીધા અને પછી તમે કહો કે એન્ડોસ્કોપીથી કરો છો એનો ચાર્જ વધારે થશે તો પછી
So that patient has to take the call. If they want it as a cosmetic procedure, they should have to spend. They will have to spend it.
yes. So that's what I wanted to know actually.
So
That what is the
practically, we don't say that this is the only technique. This is one of the techniques
One of the
that can be offered.
right?
Center નથી. સીધું કરો. So I have kind of raised, you can see the tracheal rings here.
Yes. Now I think they are little visible.
They are
We can
visible.
appreciate now.
Okay.
Yes, yes, we can see now tracheal rings very clearly.
આના વસ્તુ માટે બહુ fogging થાય. જાઓ દો. In. Clean. So once I have identified the isthmus, I will go right along the anterior tracheal wall and cut the isthmus. So do the isthmectomy as first procedure. So my midline thyroid attachment is cleared. I can
Okay.
hold the thyroid tissue for further maneuvering.
Mhm. So now from inferior, you will come gradually to superior side.
Yes. So for first thing is this, then we will take the superior thyroid.
Okay.
Partial layer. Partial layer.
Could you see the parathyroid? I think here they have not come.
I'll show you. I'll
perfect.
during the going. So I'm gradually going towards the midline
Mhm.
onto the anterior tracheal wall and taking the
So from this trachea, you can come gradually superiorly and you will encounter the isthmus.
I'm so taking the isthmus right away.
Okay.
चलो पहला आ कर ले एक ब्लीडर के अंदर ब्लीडर ब्रदर देख पाड़ो सब देख पाड़ो
Mhm. Siddharth bhai,
जी सर
we would like to see the recurrent and external laryngeal now. If
so
you
the
could-
external laryngeal nerve is not seen always clean कर दो.
Okay.
Recurrent we will see clean करो once I remove the dissect the superior pole.
Okay. So just show us if possible, and if it is visible, then you
We
just.
will show you. We'll show you. I'll show you. I will show you the recurrent definitely.
And what
That has
landmarks?
to be, that has to be seen before committing the medial cut.
Mhm. And what landmarks you use for their identification?
So the landmarks is like once I dissect the superior pole,
Yes.
you have to be into the subcapsular plane. So you stay close to the thyroid gland.
Right.
It's
That is
not
a-
like conventional triangles, jewels, and other triangles that we
Yeah.
see for defined for open.
Yes. Jaw triangles
But
and
here,
ears.
the goal is to stay close to the thyroid gland.
So when we are working near this superior pole, we should be as far as possible.
Yes.
We should remain very near to the superior pole. And that will
Yes.
save the
So
external laryngeal.
yeah.
And for the inferior, we should keep ourselves very away from the thyroid.
So
For
the
inferior-
entire rest of the thyroid will be dissected, seeing the nerve.
Right.
So once I'm done with my isthmus, as we are
Okay.
going almost about to finish the isthmectomy.
Right.
So this is the rest of the go down.
Mhm.
अंदर जाओ. Yes. Show them. Yeah.
Introduction का बता दें अब मुझे. Introduction. तो बाद में time नहीं लगेगा.
Out.
ये
In.
और कर- बोलेगा उसको. अभी तो इतने बैठे हैं अपने. शायद बाद में वो भी ना रहे. सब भग गए.
So you see this tracheal wall. So we have done the isthmectomy. I'll show you the tracheal wall and the isthmus which is cut.
Right. So now you will detect that this cut end of the isthmus is. And
This
then
is the
go.
cut end of the isthmus.
Okay. We can see the trachea. Just below it.
I'll just clear that breeder part.
Mhm.
section. तो पानी नहीं है बड़ा In, brother. Saline. On. Yeah, okay. इनो कर दो, वो बिनो कर दो, अंदर आ जाए यार, करो क्लीन करो, क्या वो करो, हाँ बस. One saline, one. Going. So you can see here, this is the trachea.
Hello. Hello.
Grasper.
Yes, sir. Yes, Siddharth bhai.
Yeah, so the trachea is seen. I have dissected, I've done the isthmectomy.
Okay.
Now we are heading for the superior pole. This was the pyramidal lobe.
Okay. Yes, yes, we can see this
See
pyramidal
the
lobe.
pyramidal lobe.
Yes, yes, yes.
So
So this
now,
will go.
now we'll go for the superior pole.
Okay.
Nothing. CO2 leak થાય તો થોડુંક બંધ કરો ને. Thank you.
Actually, Siddharth bhai, we started this session without any formality. So directly we jump to this surgical.
Yes.
But
That is important. That most important part is done first.
but the audience would like to know about you. So I am just requesting our professor, Dr. K.K. Rathwala. So he will introduce you
Clean karo.
to the delegates.
So
Hello,
now
yeah.
we are heading for the superior pole. You want me to hold on for some time?
No, sir, you can continue, sir. Whenever you
Okay.
feel that the steps are a little bit right now, we'll give a brief introduction of you, sir.
Sure.
Yeah.
Sure.
Thanks so much.
Thank you. Going. I'm rocking it out. Yes. Perfect. CO2. Perfect. Chalo.
Hello, yeah. Good afternoon, everyone. We just like to introduce our eminent operating surgeon right now. That is Dr. Siddharth Shah. He is senior head and neck cancer surgeon, and he is right now located at Zydus Cancer Center, Ahmedabad, Gujarat. Now, he has a more than 15 years of clinical experience in the management of head and neck cancer, and his expertise lies more in minimal access of head and neck surgery. As such, he has attended many cancer centers, as well as he is an associate prof at the Department of ENT and Head and Neck Surgery at Sri Krishna Hospital. He did his MS from BJ Medical College, Ahmedabad. And no way to say he is the pioneer of transoral endoscopic thyroidectomy surgery in the Western India, as well as the pioneer and one and the only surgeon, I feel, in our Gujarat region also. So people would like to imitate him more now, and a marvelous work in this field. our professor of surgery has also come, head of department. He will ask you some more questions about it. Yeah.
I would happy. Thank you for the introduction. I will be happy to take the questions.
Right. Thanks, sir. He's dissecting the superior pole right now.
Oh, welcome to our institution, sir. This is Dr.
Thank
Madhavan
you
here.
very
I'm
much
from the surgery
for the warm
department.
welcome.
I just joined now.
Sure.
Yeah.
Thanks for coming and joining with us.
Oh, great, sir.
So this is the superior pole area that we are dissecting. The thyroid superior pedicle is going to come here. વાર બહુ કરે છે આ કટ કરવામાં બહુ વાર કરે પેલું વાર એનો વાંધો નથી પણ ટાઈમ આપણો વધી જાય છે.
So for the superior thyroid vessels, you will tie these vessels as close as possible to the superior pole of the thyroid gland.
Yeah, so here this is the superior pole. I am kind
Right.
of holding it. Now we will dissect the superior pole so that the
Okay.
pedicle is identified.
Right, right. Okay.
Go in, brother. Move for clean nothing. Yeah. So here gradually we'll try to kind of lift the superior pole completely.
Right. This pyramidal
You have lot
lobe
of
also-
network of vessels here.
This pyramidal lobe also it will go along with the specimen.
Yes, sir. You should always remove the pyramidal lobe whenever doing a thyroid surgery,
Mhm.
because in such when suppose this turns out to be a malignant lesion in some cases,
Right.
when you are doing a total thyroidectomy, this is the area where you will leave behind the thyroid tissue, and that
Okay.
will show a residual uptake on the iodine scan.
Mhm. Here we have the facility of this frozen section. So if you feel like, then you can use that.
So frozen, yes, but frozen for thyroid lesions are not very beneficial or helpful because
Hmm.
the pathologists, they won't be able to tell us about the lesion whether it is benign or malignant in when it is a adenoma.
Okay.
Follicular lesion. When it is a follicular lesion, they will not be able to give us any conclusive on frozen.
Mhm.
However, if you have a lymph node in this region,
Right.
you can send it for frozen to confirm whether that is having any thyroid cells.
Understood. Okay. Okay.
So a bit of bulky thyroid lesion this. So
Mhm.
I just am trying to separate it from the lateral. Bone halao, so please. So that I can hold it properly.
Mhm.
પાછળ આવો, થોડુંક પાછળ. I mean, it requires lot of patience that you need to be having before
Yes,
you
yes.
enter into this thing, because it's not a thing easier to do. You have a lot of struggling on the hand also that you are facing.
Right.
There's limitation on the movement that you can do.
Mhm.
These are linear instruments. Like in
Mm.
robotics, you will have more of instruments which can do end or wrist movement, so that your move like it moves your wrist. You are moving your wrist.
Mhm.
Here it is only a two-dimensional movement that you can do.
Right.
वारे वारे करવું પડશે. Brother, please. અહીંયા નીચે રહો. Clean करो brother. Clean the instrument. Be ready fast. Going. Going.
सभी जगह पे कुछ ना कुछ चल रहा है.
I'm trying to lift the thyroid entirely from the Barry's ligament area
Right.
because the upper pole is still not very, it's very deep inside. I'm not able to lift it. So I'm trying to free it more medially so that I can handle and maneuver thyroid better.
Sir, in this, would you be attempting to demonstrate the recurrent laryngeal or the?
I'll show you because it is still deeper.
Okay.
So the moment I lift the thyroid gland, it gets freed from the superior pole. I'll be able to show you the nerve. At this stage, it is, I'll try to see if I can show it from the medial part, from this end.
So another query, as you are lifting off the thyroid from the base, connective tissue, what are the attempts that one needs to keep to identify and preserve the parathyroids?
So medial part is okay, there is no problem. When you are going on the lateral part, you have to stay as close to thyroid as possible. So that is known as the intracapsular dissection. So you dissect in between the true and the false capsule of the thyroid so that you don't danger the parathyroids.
Okay, sir.
And you have to ensure that the blood supply to the parathyroids is also maintained and preserved. Now, just bear with me a bit of struggle here because the thyroid lobe is quite big on the superior side. I'm not able to catch hold of the upper pole. So as soon as it gets happened, you will be able to see the entire thyroid very easily. Just trying to push and do it. પાછું નીકળી ગયું છે આગળથી. ઉપર જો પ્રેશર જ નથી, લો જ નથી, ખુલ્લું જ લાગે છે નીચેથી. બંધ કરો. ફાસ્ટ કરો યાર, ફાસ્ટ કરો. હજી ક્યાંકથી લીક થતો હોય એવું લાગે છે, અવાજ આવે છે. ચલો બ્રધર, ચલો અંદર દેખાડો. આવું શું કરો છો? ચલો. I'm individually now taking vessels because I'm not able to see the entire pedicle. So each vessel I'll be taking separately.
Right.
Oh, time. Because then if I try to go for upper pedicle or the entire vessel, it is difficult because it's quite deep
Right.
underlying the muscle. So I'm taking individually vessels which are coming onto the upper pole that will allow me to free the upper pole. So we have to kind of keep on changing the technique or maybe find out a way of solution to tackle the situation, because it may not be always simple and easy to do it the similar way all time.
This Berry's ligament, again, they say that it's quite good landmark for the recurrent laryngeal.
So the recurrent will be on the lateral part of the trachea.
Hmm.
Yeah. So once I kind of lift the upper pole,
Right.
I'll be able to see the lateral tracheal wall, because to some extent I have dissected from the midline.
Mhm.
I have already kind of separated. It's only a finer attachment which is remaining there,
Mhm.
which I'm not going right now blindly because the recurrent entry will be in this location.
Right.
So if I just blindly do there, if I do blindly, then I'm going to hit the recurrent at the entry point.
Mhm.
So that's to prevent that I'm not blindly cutting or dividing the isthmus. Otherwise, the Berry's part there.
Berry's
Otherwise, it will be
ligament.
a very easy job to lift the thyroid from there and do the procedure. But I'm endangering the nerve at that position. So that's why I'm not blindly doing it. I
Okay.
am taking time to dissect this upper pole. Clean करिए आपने यार. Clean करिए आपने गंदू से. ठीक है. No, this is the strap muscle. So there was a question here whether this area is the entry. No, this is the strap muscle. I am going underneath the strap muscle. I'm trying to hold. So this was the cyst which has got ruptured. Probably that was holding up the thyroid cyst which was there, which was kind of preventing me to hold. So I've kind of ruptured and decompressed the thyroid, which will give me some space to work. Yeah. We can divide. We can divide if you want. I initially thought of doing it just to create a space. I can do that. So there is a question from OT whether you can divide and separate these strap muscles. Yes, you can do that, so that gives you some space to work. Your retraction becomes easier. Your going beneath the thyroid will become easier. Ratu antaro networking makin kampase. Yes. Option आपको. અગર આપણે અંદર જઈએ ત્યાં સુધીમાં બહુ બ્લીડિંગ થઈ જાય છે એટલે થોડુંક ફાસ્ટ કરી દો મુવમેન્ટ. ક્યુટ બંધ કરો, લીક બંધ કરો, નથી દેખાતું. So gradually it is coming out. The more vessels are freed, the upper pole is loosening up. So now when I dissect here, will our recurrent will be in this region. પણ ક્લીન કરવું પડે આગળથી. So I'll gradually kind of dissect out tissues here, staying close to trachea. Brother, નીચું રહીને જાઓ, નીચા રહીને જાઓ. અરે યાર. Brother, આમ કરીને આમ જાઓ. Suction up. This is still the thyroid surface. Wash આપું છું. પાણી ચાલુ કરો. પાણી. Pressure આપો પાણીનો. suction up. So here is somewhere we'll be able to find the recurrent. निकड़ी क्यूस है saline. The thyroid puncture take use and that's why it is bleeding. Will keep on bleeding. काम करिए ऐसा भी चाहिए नीचे से फ्री करे ना ऊपर ले जाइए brother on the Joshua. Yes, show me there. અગર કાંઈ દેખાતો નથી મને હા અંદર આટલું ગંદુ ક્યાંથી જોઈ શકીએ કામ કરી શકાય જલ્દી જલ્દી કરો ફાસ્ટ ચલો લાવ please. અને નીચેથી ક્યાંથી આપી શકાય યાર સક્ષમ તો બ્લીડિંગ થોડુંક છે વધારે me and that's why the bleeding plane is not that clean. I'm trying to control that part so that the field remains cleaner. Sorry. So whenever we are doing something close to the nerve, the blades of the instrument, the inactive one should be towards the important structure so that you don't inadvertently damage the nerve. Okay. There is a bleeder here, the inferior thyroid vessel. Brother, na halshone, please. Saline connect करो please. Saline. Pressure ઓછું થશે. હા એટલે છે ઇન્ફિરિયર થાઇરોઇડ ની પાર્ટ. ઓનલી થિંગ ઇઝ કે હું એ છોડું છું ને તો અહીંયાથી ટ્રેક્શન જતું રહે છે એટલે આઈ એમ વેઇટિંગ થોડુંક ઇરિગેશન કરશું ને એટલે બંધ થઈ જશે વાંધો નહીં. અને આ જ એરિયામાં રિકરન્ટ હોય એટલે can't be very blind into coagulation. પાછું નીકળી ગયું છે. ક્લીન પ્લીઝ. એકચ્યુઅલી ધીસ થંડરબર્ડ છે ને એમાં પેલાની અંદર છે ને મને કર્વ ટીપ સક્શન ડિસેક્શન માટે પણ કામ આવે. આમાં મને નથી થતું. હોલ્ડ કરે ઇટ્સ લાઈક અ ફોર્સેપ્સ મેરીલેન્ડ જેવું જ. એટલે હોલ્ડ કરે અને ઉપર 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 મને જોવા દે યા કઈ વાંધો નહીં.
લિફ્ટ કરીને જોવું પડે ને નહીંતર વેસલ ની નીચે પાછી પેલી ના આવી જાય ફ્રી કરંટ. પેલું આપતો ટ્રાન્સફર સેક્શન કેવી રીતે આપો છો? પાછળ આવો પ્લીઝ. પ્રોબ્લેમ છે યાર, આનો બહુ જ. ઇન્સ્ટ્રુમેન્ટ જો આગળથી નીકળી જાય છે તમારું. કદર આટલું નજીક ના હોય, મને થોડુંક દેખાવું તો જોઈએ ને. વેસલ ફિલર નથી. નીચે લઈને પછી જાઓ, નીચે જાઓ અને ઉપર જાઓ પછી. હા, કેવી રીતે દેખાય? એમાં કોઈને બહાર દેખાતું નથી હો. આવી રીતે તો કેવી રીતે દેખાશે? ક્લીન કરો, ફાસ્ટ ક્લીન. Where I have to work. Show me where I'm working.
ક્લીન કર ત્યાં સુધી આ that's upper pole which is now pedicle આવ્યું આટલી મહેનત પછી ક્લીન કરો ત્યાં સુધી સર તમે મને દેખાડો અંતર ગેસ જ નથી અંદર રક્ષણ આપ પ્લેન નાખો પ્રેશર જ નથી મેરીને નાખો હવે પોલ આવી ગયો તો આમાં છે ને ડીપ હતું પોલ મસલ ની નીચે એના કારણે આપણને થોડું વધારે ટાઈમ લાગે નાઉ importantly is to dissect the identify the recurrent
Yeah, વસ્તુ છે. That so we'll gradually take all this tissue so that it gets separated. Recurrent જેવું નીચે જ લાગે છે મને એ છે ને recurrent જેવું છે. So we'll just એટલે we'll gradually go there, staying close to thyroid. Akshara. Play now. So this is recurrent. देखा? Right. This is recurrent. I'll make a wash. Give a wash. So this is recurrent. देखा? હવે એને dissect કરીશું ને તો આવશે. We have to keep this, following this. Keep following this down. This is inferior thyroid artery. Sorry. ખબર નથી મને સંભળાય છે કે નહીં. Hello. Am I audible?
Hello. Hello.
Hello, hello, yes, we can hear you.
Dr. Siddharth
so-
sir is.
So now this is recurrent, sir. Whatever we were wanting to see, this is
Right.
recurrent. You can see this white
Right.
structure.
Yes,
That's
yes,
recurrent.
yes, we can see that.
Yeah. So now there was a bit of struggle during the process. Now we are finally almost through.
Right,
Now keeping this in view, we will dissect. We'll take the median part.
okay,
So I'm keeping my non-active blade towards the nerve area. You can see this
Okay.
is the nerve.
right. So that non-active, that blade, that will remain on that side.
Yeah. So I'll keep it close to the nerve.
Okay,
Confirm it again and again that, brother, एक minute side just please, that I'm not hitting the nerve.
mm-hmm. The specimen is almost out.
Almost out.
Yes. But those efforts and patience, that was worth.
Sorry, sir.
That patience, your patience and your effort, they were worth.
We need to be very patient for all this, sir, because I can't compromise the nerve for this patient.
Yes, yes, true.
I know it is not an pleasurable to see when somebody is struggling,
suction.
But the people,
And
they
you
can
have
appreciate.
this area which is bleeding.
Right.
Now this patient probably had lot of a bit of vascular lesion.
Okay.
Now
the
the nerve will
reports-
be very well clearly seen. Now it's only the this much portion of the vessel which is the inferior thyroid part which is there.
Okay.
This you can see the nerve completely here.
Right.
Okay, so this area is something which needs to be cleaned now.
Mhm.
Only this one.
With that irrigation, what you were telling, that that bleeding also that stops.
So I keep irrigating this area in between so that the planes are drained of the blood, and you can see the tissues underlying very clearly.
Right. यहाँ सभी ने एंजॉय किया सर आपका डिसेक्शन.
Sir, I thank you very much. So this is the last part of the thing. Once we remove this, its medial dissection and the superior dissection is done, there will be few vessels which will be
Okay.
attached to the lower pole.
Right.
This is not getting rotated. See, this nerve is there. I'm protecting it. Keep always the nerve in view before you apply your clamps or vessel, this thing, thermal device.
Okay.
દેખાડવાનું છે, અહીંયા દેખાડવાનું. બધા તમે ક્યાં મારે જોવું છે ને ત્યાં દેખાડશો ને તો જ કામનું છે. હા, show this. Come. So we are just checking where all till there is attachment of the thyroid. Suction.
ठीक है जी.
મયુર, મારી જે બેગ છે ને એના ફ્રન્ટ પાર્ટમાં બેગ છે, એન્ડો બેગ જેવી મગાઈ લો.
Bag आपसे.
So now this is the last part of the thyroid which is attached to the lateral soft tissues.
Okay.
ला. Laptop bag.
पहले મારી વાત સાંભળ, એની પણ એક રિપોર્ટ બનાવવાની છે. એ સાયલોન્ડોસ્કોપીની બનાવી હતી ને એની પણ બનાવીને અને આઈસીયુમાં આવતી ત્યાંથી બનાવી આપી એને કે અહીંયા આવવાનું છે ટ્રીટમેન્ટ.
YouTube બંધ કરો ને અંદર બંધ કરો બ્રધર, લીક એ તો ભરાશે નહીં.
मैं किसी बात कर लूं?
क्लीन कर टिप क्लीन करो. चल जल्दी ला. बाइपोलर अब जो बाइपोलर रेडी कर. लाओ तो क्या સુધી आप तो हार्मोन आप तो जल्दी जल्दी आ. Brother, please move your head. ટેફલોન કોટિંગ નીકળી ગઈ છે. ટેફલોન નીકળી ગઈ છે આની. આ પેરાથાઇરોઇડ છે. Yeah, this is parathyroid. So this is parathyroid.
Yes, Siddharth, yes,
This is parathyroid.
yes.
So this is the last attachment of the thyroid.
Mm.
And once this is done, our thyroidectomy is done. Go close. You can see that the thyroid is free now. CO2 बंद करो प्लीज. लीक बंद करो. सलाइन सक्शन. So I'm giving the wash in the tube in the bed so that we can identify if there is any active bleeder anywhere. પાણી પતી ગયું છે. So I'll show you the recurrent here. You can see this recurrent here.
Yeah, it's beautifully seen.
And this is the parathyroid.
Yes.
In this, we don't put any neck drains. We just ensure that there is adequate hemostasis at the end of the procedure. Uh, 0, ha, 5 mm વાળો મગાવેલો. નાનું પડશે આ તો. સ્પેસિમેન નહીં જાય આમાં.
You will remove in piecemeal or in toto?
No, we will remove in toto. So I'll put this now. I think તમારા લોકોને endo bag હોય કે wherein you just specimen, put it in the specimen and you have a device which you just pull it. Here in thyroid, we don't have a preformed endo bag available. So what I generally do is I create a endo bag by making it from a plastic bags that we get as a drain material. The drain romovec ave એની અંદર જે plastic tubing ave, I mean the drain which is there into the plastic covering, I utilize that as an endo bag, create endo bag from it. So around 7 to 8 centimeter by 5 centimeter width at the maximum that we can afford to have in the neck. The routine endo bag size that we have as a laparoscopic endo bag available is, I think, more than 10 centimeters width. So the mouth, what we want is not smaller that is available commercially. I'm trying to find out if there is some place where I can get a smaller endo tube, endo bag, sorry. But still, so what we generally do is like external camera batao, light curtain. So you can see this.
Yes,
Now this is for the Foley's catheter, that you get a covering on the Foley's catheter.
Yes, sir.
Now for this patient, this is going to be a smaller width because this is hardly 5 centimeters. Once I put it inside, the specimen might not go into this thing. So we'll need a bit of larger mouth so that the specimen can be easily slided. So this is what I'm going to kind of make it from this plastic bag that we had for drain. Sorry, the suction catheter, the Yankus. So I will have to seal this region with a, they have that sticker for the ETO or sterilization. So that we will kind of cover it here. Half on this side, half mein arm rakho. Just hold it two ends. Yeah. થોડું પછી લેગા. So this is, we have kind of customized it, made it. Now this routinely through the central port, we will put this inside the neck. And we'll put the entire specimen in this bag. And we will remove this specimen from the mouth incision, the central incision that we have put. To put it like a fan shaped, you put reduce the size of it and hold it with the grasper and put it through, push it through the middle central area so that it goes inside the neck. And you put a 5 mm smaller camera through the other port so that you see the bag inside the neck, and you put the specimen within this bag. You want to on karo na please. Light off.
હવે પાછું 10 mm લઈ લો. આટલું બધું પેકિંગ ના કરો, વારે વારે ખોલવાનું જ છે. એન્ટીબાયોટિક આપેલી છે ને? ક્લીન કરો, આગળની ટીપ ક્લીન કરો. ચલો 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 ચલો. Push it, push it, push it, push it. Basically. Going. So that's our bag which is inside. Leak થાય છે ક્યાંક CO2. પાછું ખુલી ગયું છે. So open up the mouth of this bag and slide in the entire specimen. So the important thing is the wider part we should try to put it as low as possible, deep inside, and the thinner part of the specimen stays above so that it gets decompressed while we are removing it through the mouth. I'm pushing the specimen inside the bag. You have to ensure that it gets completely inside. લાસ્ટ મોમેન્ટમાં તમે સરખી રીતે નહીં દેખાડો તો તકલીફ પડશે. ક્લીન. મારે અહીંયા આમ પકડવાનું છે, પકડો. મને દેખાડશે બ્રધર, તો જ મને ખબર પડશે ને. ક્યાં દેખાડશો? થોડુંક, હા બસ એટલું રાખો. છે અંદર જ, ઉપર ખાલી ફેરવવાનું છે થોડુંક. બ્રધર પ્લીઝ દેખાડો. હવે જીબી એક્સટ્રેક્ટર જોશે આ પકડવા માટે. So I have placed the entire specimen in the bag. You can see all around. Now we'll put a GB extractor to hold the specimen and pull it out through the central endoscopic port. 5 mm, 5 mm. આ બધું નાખજો. GB extractor ક્યાં છે? પાસ કરો ને બ્રધર. આ પકડી રાખો, મેં પકડ્યું છે. છોડો, પકડ, એક જ મિનિટ. ઓકે. ઓપન કેસે થાય? પકડજો. ના. છોડ દો, છોડ. ચલો, ઉપરની લાઈટ આપજો. આગળ જાઓ બ્રધર. ટોપ લાઈટ. રિટ્રેક્ટર લાવો. રિટ્રેક્ટર. બરોબર 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 બરોબર. CO2 બંધ કરી દેજો. ખોલ નાખ. અને આ બેગના પ્રોબ્લેમ એ જ છે, આ પ્લાસ્ટિક બહુ તૂટી જાય. લાવ. છોડ. છોડ. ના, નહીં જરૂર. છોડ. બેગ પાટલ છે. પકડ. So you kind of decompress it by removing smaller, thinner portion. The બીજું બધું portion છે ને becomes easier to be delivered. ફાટી રહી છે પ્લાસ્ટિકની થેલી. Option point tip. બસ. બીજું લાવ. બીજી આર્ટરી. છોડ દો. પકડો. हेड सपोर्ट करो प्लीज. એને દબાવવાનું નહીં તો ખાલી માર. ના રિટ્રેક્ટર મૂકો જગ્યા ઓછી થઈ જાય. ઓલમોસ્ટ આવી ગયો. That is problem. Good. Sure. Take knife up. Mosquito. Plastic bag is not good, no, that's why ફાટી જાય છે બધું અંદરથી. સ્પેસિમેન અંદર રહી જાય એના કરતા better that we remove it from here. લા બીજી આર્ટ ક્લીન કરો પ્લીઝ. પ્લાસ્ટિક જ નીકળે છે. અરે એક સેકન્ડ બ્રધર. હેડ કોણ સપોર્ટ કરો યાર.
એવું છે મારું ચાલે
નો નાખતો તું સ્કિન ને. just decompress જ કરવાનું છે actually. This bag is getting torn. That's why I opened up here, because then there should not be a spillage inside. Otherwise, we would not have opened. This bag is not the ideal bag. So this is the specimen. What?
Hello.
પેલા ઉપર સ્ટીચ આપી દો ને મને. એથિલોન આપી દો.
Hello. Bansal sir.
30 અથવા રેપિડ વાઇકલ રેપિડ લઈ લો, અથવા વાઇકલ છે રેપિડ 40 આપી દો.
Hello.
Hello.
Ground body.
Sir,
Yes, sir.
Sir, you saw the specimen? You see the specimen?
You
Yeah,
have
this
seen
is
the
the specimen.
specimen. Yeah, it's quite big, looking quite big.
Yes.
So the bag was a bit of thin and it was getting torn.
સિદ્ધાર્થભાઈ, અહીં બધા ક્લેપ કરી રહ્યા છે.
Thank you, sir. Thank you. So we'll just confirm the hemostasis and close.
Right, right. Again, for hemostasis, you'll be just irrigating the area.
I'll put the drain inside. I'll put the scope inside.
Okay.
Give a wash, thorough wash, check for the hemostasis and come out.
Right, right.
Thank you. Thank you.
Rather, we should thank you, sir. We are feeling obliged.
Thank you, sir. We'll ask the anesthetist towards the end to check for
Okay.
the vocal cord movement.
Right, right.
So we have seen the nerve, it was in continuity.
Yes.
If at all there is some bit of thermal injury, there'll be praxia because of the heat
Edema.
dissection. Yeah, so the kind of a praxia,
Right,
which generally recovers within 6 weeks.
right.
So till that, patient is asked to perform regular speech therapy for
Okay.
maintaining the tone of the vocal cords.
Right.
Central trocar. Saline ready. Saline ready. क्लीन करो टिप सलाइन लेंस क्लीन करो CO2 ऑन कर जो ब्रदर चाल तो बंद मत करो खाली सलाइन થી ક્લીન કરો चलो ब्रदर फास्ट करो ना प्लीज Table down. સામેથી ફોટોગ્રાફ ખાલી લઈ લેજો ને. છોડ દો. CO2 on. નથી on. છે જ નહીં, અહીંયા જ નથી લગાવેલું.
શું फोटोग्राफर
Select
के सबका ग्रुप फोटो जो है ठीक किसी के पास तरह गमते कोई नहीं कहे ना
Align does નથી આવતો. There is no saline.
પછી પછી
We are checking for the hemostasis again. I'm giving thorough wash inside the neck so that any small bits can be cleared to prevent adhesions.
would you like to irrigate the area with betadine so that it can take care of local infection?
No need of betadine because we don't think that there will be any infective component here. We are
Okay.
sealing off the oral cavity again back.
Okay. So the patient will remain on little liquids only for a couple of days.
No, sir.
Or
So from tomorrow onwards, patient should be given all food, routine
Okay.
diet,
full diet.
full diet orally.
Okay. From tomorrow only. Tomorrow.
Tomorrow
itself.
onwards.
Yeah.
Today, I mean, evenings he can start liquids,
Okay.
all
today,
liquids.
today evening we can give the biscuit.
Yes, we can start oral liquids completely, and tomorrow onwards, full oral diet, solid diet can be
Okay.
taken.
Okay. Yes, so usually
So now
anesthesia say.
we are going into the neck area, the lateral neck.
Mhm.
Okay, scope પકડજો અને saline બંધ કરજો.
સિદ્ધાર્થભાઈ બધાને ખૂબ મજા આવી.
Thank you,
ખૂબ
sir.
મજા.
Last, I'll
ખૂબ.
show you the recurrent.
Yes. તમે ખૂબ મજા કરાવી રહ્યા હતા.
Thank you, sir. This is the parathyroid which is seen.
Right. ટ્રેકિયા સર દેખાય છે આપકો ટ્રેકિયા.
That's the recurrent.
Oh yes. There is no oozing right now, nothing, it's almost dry.
So convinced for the recurrent, sir, and the parathyroid.
Okay.
Okay, छोड़ दो. CO2 बंद.
Top light चालू.
So regular suction आपण બેસવા આપી દેજો. Plastic suction. કેમ કાપી નાખ્યું તું? આ નથી બધું CO2 આવી જાય પાછું બહાર. વોશ મોઢામાં. આપણી પાસે પેલું અહીંયા પ્રેશર આવે છે, પ્રેશર ચીન સપોર્ટ જેવું, આમ ચીન સપોર્ટ જેવું કઈ આવે છે?
બેન્ડેજ કરી
ડાયનાપ્લાસ્ટની તો જરૂર નથી. પેલું સ્વિચર આપો ને, બસ વોશ આપો. ખોવાઈ ગયા બધા. ના ના, ડાયનાપ્લાસ્ટ નહીં. એટલે ક્રેપ બેન્ડેજ સરકી જશે. ના પડાય યાર. જોઈએ, ચલો અત્યારે મગાવી રાખજો.
શું થયું? નહીં, કાલની રજા છે કે નહીં કે પહેલા? હે કાલે રજા છે હોસ્પિટલ બંધ, તો આપણે હોસ્પિટલમાં છીએ, કોલેજમાં છીએ. પેશન્ટ ઓલમોસ્ટ લાઇટ જ છે ને. આવી ગયું, સ્વોલોઈંગ મુવમેન્ટ આવી ગઈ. થેન્ક યુ. બીજું સલાહ? અરે યાર, લાવ. બસ. થેન્ક યુ. હા, એકિમોસિસ છે ને, એ જતું રહેશે. સ્કિન એકિમોસિસ છે ને, એ તો જતું રહેશે વિધિન અ વીક. થેન્ક યુ ઓલ. Thank you, Siddharth bhai. Hariti, once
Thank
more.
you, sir.
Yeah.
Thank you. So that
We
brings
appre-
to end of the surgery. We have closed
Right.
the intraoral wound with Vicryl 4O,
Okay.
and we have given a thorough mouth rinse or to clear all the saliva and the blood stained secretions.
Right. Right.
And once this patient is extubated, I'll be in the theater to check for the vocal cord mobility. Now,
For what?
if at all there is mild weakness, it could be just because of we have seen the continuity of the nerve. So it will be just
Okay.
kind of a
That
praxia
will
if at
come.
all
Yeah.
near the recurrent entry. But I
Right.
still do
Right.
not expect that also. And since we
Right.
have done a heavy thyroidectomy, we saw the parathyroid also,
Good.
which
Yeah.
was very normal looking. It was not dusky nor dark colored. So that means it has a preserved circulation also.
Right.
So we
Right.
do not
Right.
expect any hypocalcemia for this
Mm-hmm.
patient in the
Right.
post-operative period.
Okay.
At the most, if you want to check for any parathyroid when we are doing a total, we should have a baseline PTH and a post-operative PTH. If both the PTH are normal, probably there will be no chance of hypocalcemia.
Okay. So
This
that
is
I,
in case when we are doing a total thyroidectomy.
right. 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 Thank you, Siddharth bhai.
So,
बताने खूब मजा आई.
thank you, sir. Thank you for the opportunity. Thank you. The entire OT staff was very helpful,
Right.
supportive. The entire anesthesia team who
Hmm.
maintained a very good field during the surgery.
Right. That will
Thank
could
you,
see.
sir, for inviting for this workshop. And sorry for a bit of delay and
No.
bit
No.
of glitch in between.
No. No. There was no delay.
Thank you, sir.
Yeah. હજુ આપણે બીજા 5 મિનિટ લઈશું little validity function we have kept. So you come to that
Sorry, sir.
committee. એક validity function ઉમેરો રાખ્યો છે. તો આપ કમિટી રૂમમાં આવો પછી validity function.
Let us put a crab bandage. No problem. Sorry, Dynaplas.
इधर आएंगे.
આટલું જ છે.
બરાબર બોલ્યો નહીં.
એવું કરજો.
મયુરભાઈ.
આટલું ના
મયુર.
આટલું વચ્ચે આખું રાખવાનું.
ડોક્ટર મયુર.
આગળ સીટ એટલે શું થાય કે એક ઉપર જાય એક નીચે જાય. હું કરી આપું ચલો.
નહીં દેખાતો
Scissor
નથી
આપો.
અહીં નથી. એ આવ્યો નહીં. આવ્યો.
Yes, sir.
હા મયુરભાઈ.
Hello.
બસ
હા, sir.
સાહેબને કમિટી રૂમમાં લઈ આવજે અને અહીં
હા સર ત્યાં લઈને આવું છું. યસ સર. હા
હા અહીં લઈ આવજો બસ.
હા સર શ્યોર.
હા ઓકે થેન્ક યુ.
તમારો ચોટી જશે ગ્લોવ્સ છે ને. એક સેકન્ડ. એક જ મિનિટ મેડમ.